Now we start our session, and the next presenter is Vijay Kumar Prajapati. He is assistant professor in the University of Rajasthan, and he will be presenting on in vitro susceptibility of L. donovani to miltefosine promestigotaceae. Vijay. Mike.
Okay. For today presentation, my presentation topic is susceptibility assay of Leishmania donovani to miltefosine based on the promestigote assay. So to conduct this type of experiment, coming to the introduction of the visceral leishmaniasis. So visceral leishmaniasis is mainly confined to the Indian subcontinent, mainly in the India, Nepal and Bangladesh. So to conduct susceptibility assay of Leishmania donovani to miltefosine, we isolated a mastigote stage of the parasites from the patients and then cultured this a mastigote stage of the parasites in the promastigote stage. So for that, we collected the splenic aspirate in the NNN tube culture, and this was the primary culture. So we kept splenic aspirate in the presence of liquid medium, which is M199, into the NNN tube, and then after we incubated this NNN tube into the BOD incubator for the say 7 days. And after the 7 days, we checked the parasitic growth, or you can say the amastigote conversion into promastigote of the Leishmania donovani. And if there was the presence of the parasites, then we transferred few drops of the parasites into the liquid medium of the flask in the 5 ml medium. So we grown these parasites, we grown this promastigote stage of the parasites into the multiple number in the BOD incubator. And when these parasites came into the stationary phase after the 5 to 6 days, then after we conducted our drug susceptibility assay, and simultaneously to save the parasites, to save the promastigote stage of the parasites, we conducted some quality control of the experiment. We periodically checked NNN tube for the bacterial infection, we checked rabbit blood, we checked medium, we checked laminar flow for any type of the bacterial infection as well as fungal infection. So this was the technique to grow the promastigote stage of the Leishmania donovani parasites, and then after we conducted drug susceptibility assay on these isolates of the Leishmania donovani, and these isolates were obtained from the miltefosine trial. And this was the problem, could we use promastigote stage of the Leishmania donovani for the drug susceptibility assay? Means, can we give some message by using this promastigote stage in spite of the amastigote stage, and could we differentiate between the pre and post treatment isolates on the basis of this drug susceptibility assay? And what are the reason for the miltefosine relapse rate, which we can give on the basis of this simple drug susceptibility tool only? So this was the problem. So to answer these problems, we conducted drug susceptibility assay on the Leishmania donovani clinical isolates. So we we obtained all the parasites from the miltefosine drug trial, and this drug trial was conducted in the Kalachar Medical Research Center, which is based in the Muzaffarpur. So all the patients were treated in the directly observed conditions, and this was the drug trial data. Means we recruited approximately 567 patients for the miltefosine trial, and the final cure after the 6 months was 90%, and relapse rate was 7%. So we chosen Leishmania donovani clinical isolates for this experiment on the basis of different parameter, or at the basis of different stages, parasites were taken from the before the start of the treatment or at the end of treatment from miltefosine non-responsive patients, and day 0 parasites from the patients having past history of VL, means those patients who are having the past history of the VL, past history of the Kala Ajar, and parasites isolated from the VL patients during the follow-up. Means if some patients are again coming up with the visceral leishmaniasis infection after the successful first treatment, so we selected those isolates also for this our assay, and all the parasites isolated at the time of the day discharge. If some patients are showing if we can grow parasites from those patients at the stage of day discharge, so we selected those parasites also for our susceptibility assay. So we selected parasites from the two type of the patients, either for, those who responded for the miltefosine treatment, means those who successfully responded for the miltefosine treatment, like cure group of patients, and those who did not responded for the miltefosine treatment, like who failured for this treatment. So we selected 10 parasites from the pre-treatment cure group, 14 parasites from the pre-treatment failure group, 12 parasites from the post-treatment cure group, and 14 from the post-treatment failure group. And then after we checked the Leishmania donovani species, means we did the typing of these parasites by using the molecular biology tool, by using HSP70 gene PCR and He3RFLP. We did this experiment because a few years ago, we had observed some other species infection like Leptomonas infection, so that we checked either means those parasites which we are going to use for our drug susceptibility assay, either these are the Leishmania donovani only or there are some other parasites. So after this molecular biology typing, we can say that these all are the Leishmania donovani. So then after we set up our this simple promastigote susceptibility assay, and we conducted this experiment into the simple 96 well culture plate, and we plated 1 into 10 to power 5 promastigote in the each well of the 96 well plate, and then after we added miltefosine drug in the each well from 0.5 to 400 micromolar concentration to check the IC50 value of the parasites, means which parasites can show the range in the susceptible region, and which parasites can have may have a tolerance for the miltefosine, means those who are coming in the high tolerance region of the miltefosine. So we, after the addition of the drug, we incubated this plate into the BOD incubator for the 72 hours. And then after we added rizazurin dye in the each well, and rizazurin dye concentration was 50 microgram per ml, and we added 50 microliter rizazurin dye, and this rizazurin dye detects the live and dead parasites, so that we can say this number of the parasites are present after the incubation of the drug for this time being. And then after we recorded the fluorescence reading at the 550 to 590 nanometer, and then after we calculated the 50% parasites, means inhibition concentration for the 50% parasites were calculated on the basis of the 11 well of the reading of the drug. So this was our result. In this result, we have this was our observation of after the experiment, like pre-treatment cure group and pre-treatment failure group of isolates have shown the IC50 in the below range of the 5 micromolar, whereas the post-treatment cure group and post-treatment failure group of isolates have shown the IC50 range more than the 5, like 6 to 7 micromolar in the range. And by this set of the experiment, by this type of the observation, we concluded that first is that we can use promastigote for the miltefosine susceptibility assay at the place of amastigote assay, because amastigote assay is very tedious process and it takes a lot of time and lot of energy. As well as there was no significant differences between the pre-treatment cure group of isolates and pre-treatment failure group of isolates. There was no difference between the post-treatment cure and post-treatment failure group of isolates, but there was a significant differences between the cure group of isolates and failure group of isolates. So from the fourth observation, fourth conclusion, we given the message that this difference, this increase IC50 in the failure group is because of the increase in tolerance. It is not the resistant isolate. Because for the resistant isolates, we should have the IC50 value near about 60 micromolar. But in our experiment, it was not more than 10 micromolar, so that we can say this is not the resistance, this is the increased tolerance. And this increased tolerance in the parasites, in the isolates, it may be due to the increased tolerance which parasites may have acquired during the treatment, during the time course of the miltefosine treatment. So this was our conclusion of this experiment. And I would like to acknowledge Kala Drug R, under which we conducted this experiment, Banaras Hindu University, Central University of Rajasthan, and SNN DZ.
So Vijay, you think that this test now can be used in the field for testing the patients for resistance?
Sir, for this question, I have two answers. Like this pro-mastigote assay is the simple tool, first of all. So at the preliminary level, we can give the information that these parasites may have the higher tolerance for the miltefosine, so that we cannot, we should not recommend those patients, means from which we have isolated these parasites, we should not recommend them for the miltefosine treatment. There is another one tool that is gene expression study. Like for the miltefosine, there are some genes like Leishmania-Donovani miltefosine transfer gene and Leishmania-Donovani ROS3 genes. So these genes are having the high level of the expression in the case of the resistance isolates. So that is another one tool by which also we can give this information. If some patients, some group of the patients are having the high expression level of these genes, so we should not recommend those patients for the miltefosine treatment.
No, but the LDMT and other genes have not been shown in, it's only in the experimental studies. They have not been shown in the human studies.
Yes, sir.
So I don't think you can extrapolate into the human conditions.
Yes, sir.
Miltefosine is an important drug. I mean, for the elimination program in India, Nepal, and Bangladesh, miltefosine is being used extensively at peripheral health, at the PHC level or peripheral health centers level. So that's why I think you can see so many presentations. Dr. Suman Rizal.
Vijay, yeah, this is actually what you have shown is because we were earlier for the other drugs like antimonials, we were looking at mastigote assays, and now we are able to use pro-mastigote assays to detect parasite drug resistance tolerance. But you showed that it is not really resistant parasites. You are not getting resistant parasites in these failed patients. So what do you think is the reasons why they are failing? But have you had any other discussions, or you looked into, like similarly, we had shown similar studies in when we did compared in fact, we had 2 pairs which were from this patient who was pre-treatment and also the same patient who relapsed.
Yes, sir.
And we did not find any significant difference in the levels of tolerance or resistant parasites. So is this due to the assay failure, or do you think There has been comparisons between amastigote and promastigote assays
Yes,
also.
sir. There was a comparison study between the promastigote and amastigote stage of the parasites, and this study was conducted by the Poonam Salotra, and they have clearly shown that for the miltefosine drug we can use promastigote assay for the drug susceptibility purpose, and we can give the information that which parasites are showing the more tolerance for the drug, and sir. For the means the isolates which we are isolating at the day 0, and suppose if we are isolating from the same patients at the day discharge, so according to me means according to from our observation means they are not showing up to the higher level. So as per our assumption and as your recent paper have shown, which is on the basis of molecular tool, that this is not the reinfection, this is not the new infection, this is the same parasites which have been acquired the more tolerance for the miltefosine, which may have acquired during the course of the miltefosine treatment. So this is one of the.
Is there any documented evaluation study on resistance of this drug? Because I don't know this drug very well, so just...
No, lot of in vitro studies, but otherwise there are no such studies. But there are a lot of relapses, as Marlene showed in her presentation, and especially from Nepal and Bangladesh. In Nepal, the cure rate is very low, 72%, 73%. In Bangladesh also, I mean, the per protocol cure rate was also 74%, and although the per protocol ITT was, if I remember correctly, it's slightly higher. So, but so far the primary resistance to miltefosine has not been documented. Everybody responds very well, nicely to the initial treatment, and then after some time they relapse. And as you might have observed in Marlene's presentation, most of the patients in India and in Bangladesh, they relapse within 6 months. But in Nepal, the late relapses are very common, and about 20% patients relapse up to 12 months. So but primary resistance, no.
And in Nepal also?
Okay, Vijay, thank you very much. So we move on now to the next presentation, which is by Dr. Raman Mahajan from MSF, who will be presenting basically on HIV-VL co-infection and its treatment with ambisome, liposomal amphotericin B.
Good morning, everyone. The focus of this presentation will be long-term treatment of HIV-VL co-infected patients treated with high-dose liposomal amphotericin B in routine program condition by MSF in Bihar, and also the prevalence estimate of HIV in VL patients. Let's start with a bit of context first. Population in Bihar is 104 million and is one of the highest densely populated state in India, which is like 3 times higher denser than Belgium. And it's in its term of geographical area, it is equal to South Korea or Hungary. It's relatively poor state. The per capita income is well below the national average. And VL account for, in India, VL account for 50% of worldwide burden of VL. It's mainly by Leishmania donovani, and Phyllobatomys argentibus is only known vector. So it's totally anthroponotic here. It mainly affects poorest population which live in shanty houses. There's poor sanitation and hygiene condition. Bihar state contribute almost 80% of cases in India. Let's come to HIV burden of Bihar. Bihar is considered to be low prevalent state. NACO, the national body for HIV program in India, estimates 0.22% of prevalence and 1.2 lakh people living with HIV/AIDS in 2012. But migration is very common in Bihar. So it's second most out-migrated state in India. There's 13 ART center, 207 voluntary counseling and testing center for 104 million people, which is quite low. In 2009, there were over 10,000 new infections, and treatment is according to NACO guidelines. One of the major concerns is that voluntary counseling and testing is not routinely offered to patients diagnosed with VL. And burden of VL, in 2008, MSF conducted a prevalence study. We estimate that point prevalence was 10.4 per 10,000 population, which is far above the elimination level, that is 1 per 10,000. And in 2007, national program reported over 20,000 cases, and 78% of them was from Bihar. This is our program data showing the trend of admissions. You can see there is a seasonal trend. It's mainly March, April, May is the peak season for admissions in our program. There is a long history of treatment for VL in India. SSG, which was introduced in 1922, but in 1980s it started getting resistance. Some of the major studies by Dr. Shamsundar sir showed that the treatment failure rate was as high as 60%. And so in 2010, WHO removed SSG from the recommended drug. Amphotericin B, which is currently second-line drug in national program, which is effective but also very toxic and also required a long inpatient stay. Miltefosine, 28 days monotherapy, which has been discussed many times here, is currently the first-line drug in national program. But presently, there is increasing evidence of increasing evidence of treatment failure in miltefosine. In our own study, we found that 1 year treatment failure rate was 8%. Especially in Nepal, the treatment rate for 1 year follow-up was as high as 20%. There's also issue of compliance and teratogenicity. That means we need to ensure contraceptive for women of childbearing age for at least 3 months, which is quite challenging in our country. Liposomal amphotericin B, which has been studied and tested in range of doses, either in combination or in monotherapy, and it proved to be quite efficacious. Efficacy in all these studies quite high, but none of these studies include HIV positive patients. HIV VL in Indian context, this important co-infection is also being neglected. Very limited literature is available on web. Mainly, if you evaluate case series, case studies, very low sample size study with very low power. One of our previous study, for 2-year outcome with liposomal amphotericin B with 55 samples, and which we followed up for median 1 year, we found that 2 years mortality rate was around 15% and relapse rate was 26.5%. We also find that CD4 count less than 20 cell, 200 cells per microliter in 6 months were predictive of relapse. And in present study, these 55 patients is part of our present study. So our present study is continuation of this study, but with higher sample size and longer follow-up. It's a pity that there is no national guideline for the management of these patients. I want to describe a bit about our project. We start our VL treatment project in Bihar in mid-2007. Diagnosis was based on WHO case definition for Kala-Azar, RK39 rapid test, which is very sensitive and specific test, clinical examination, and parasitocol diagnosis only if necessary. In project, we have observed that we only do parasitocol test for less than 7% of patients. Treatment with 20 mg per kg liposomal amphotericin B given in 4 doses. So far, we have treated over 10,000 patients in Bihar, Vaishali district, Bihar. If patient has previously relapsed with 20 mg per kg, then we were giving 20 mg per kg liposomal amphotericin B in 5 doses. In our project, VCT, voluntary counseling and testing was not routinely offered to patients under mid-2011. only high-risk population which indicate the history of high risk, we were doing HIV testing. And we found the prevalence of, in-program prevalence of 1.8%. So the objective of study is to determine the long-term outcome of HIV-VL co-infection, long-term outcome of HIV-VL co-infected patient treated with liposomal amphotericin B in 20 mg per kg doses. Methodology was simple. We used the retrospective course. It was a retrospective course study using routine program data, but quality of data was maintained. It was routinely checked. For this specific cohort, we double-checked all the data from the treatment files. Most of the patients, we do the active follow-up. So primary outcome was death or relapse. Cumulative incidence of mortality was estimated using Kaplan-Meier method. Also, we estimated the risk factor analysis using multivariate Cox regression modeling, and variable which we included were age, sex, VL treatment history, hemoglobin, BMI, spleen size, CD4 count, TB, ART state, all at time of admission. So, in this study, there were 161 patients admitted between July 2007 to August 2012. It was a mixed cohort. That means not everyone was diagnosed by MSF. 26 patients were already non-HIV and were on ART. After diagnosis by MSF, we send patient to ART center. Diagnosis is done by a series test, determine and bioline serial testing. This is this flow diagram showing the breakup of patients, analysis classification flowchart. So 43% of these co-infected patients have previous history of treatment with other drug before coming to us. So in program there was total 36 deaths, but 6 died shortly after the admission, and median time to death was 11 with interquartile range of 4 to 51. So patients were dying quite early. Estimated mortality using Kaplan-Meier method at 6 months, 2 year and 4 year was 14%, 22% and 30% respectively. So in 4 year, almost nearly less than 30% of children, of the patients died. In univariate analysis, we found that low BMI, poor nutritional status, hemoglobin less than 7, and concurrent TB was significantly associated with mortality. However, in multivariate analysis, we found that only hemoglobin less than 7 on concurrent TB came out to be significant. And ART was associated with 64 to 66% reduction in mortality. So if patient started ART, then the chances of mortality was less. So you can see in this Kaplan-Meier graph that the patient who are on ART, they have significantly lower mortality rate compared to overall cohort. VL treatment response. There was no initial treatment failure, but total relapse was 26. Median time to relapse was 10 months. So we have seen that most of our patients relapse after 6 months, between 6 months to 1 year. Estimated risk for relapse for 6 months was 1.6%, while in 1 year it was 18.5%, and for 4 years it was 31.2% respectively. And in univariate analysis, we only found that age less than 40 years was risk factor for relapse. And ART initiation during treatment reduced the risk of relapse up to 75%. So if you say this lower smoothing curve, that the CD4 count increase were very low in patients who relapsed compared to patients who don't relapse. So let's come to prevalence. Before March 2011, as I said, that we were not routinely diagnosing everyone for HIV. But after March 2011, we start offering voluntary counseling and testing for everyone over and equal to 14 years of age. And there were 960 patients who were HIV inactive and 117 patients HIV positive, which is 5.6%. Quite high, but there were also patients who were already non-HIV. So because we are getting many referrals from SKMCH, a tertiary care hospital in Bihar, who are already HIV and they sent for treatment of Kala-Azar to us. So newly diagnosed HIV were 49, that is 2.4%. And as I told you before, that baseline HIV rate as per NACO was 0.22, which means it's 10 times higher HIV than the baseline general population. We also try to find out the difference between HIV-VL co-infected patient versus immunocompetent VL patients. So we found that there were significantly more males in HIV cohort. They basically belong to a reproductive age group. Their hemoglobin count was significantly low, and also they have there's 7 times more chances that they have previous history of treatment with other drugs. Their spleen size is relatively high, and also there's more severely acute malnourished in HIV cohort. So in case, if it is not possible to screen everyone, at least male with reproductive age group and low hemoglobin count and previous history of treatment with for Kala-Azar, they should be screened for HIV. We have also seen, it's not mentioned here, but we have seen that most of our patients were involved within high mobility occupation, mainly drivers, truckers. So this point should be considered. We developed a new HIV strategy that we start to screen all VL patients, even less than 14 since April 2013. With support of local ART, newly opened ART in Sadar Hospital, Hajipur, we enroll all newly diagnosed patients. We follow NACO guidelines, ensure CD4 count every 6 months, and we are following up patients for every month. Like any other retrospective cohort study using routine program data, we have some missing value, late variable, loss to follow up. Also, because TO's test of cure was not routinely done for everyone, and we may miss some treatment failures, especially patients who die within 1 month. We don't know, they could be treatment failure. Conclusion, we conclude that 20 mg per kg liposomal amphotericin B is well tolerated by patients, good initial cure rate. Long-term efficacy could be improved if they initiate ART early. There is treatment mortality for 4 years was as high as 30%. But ART can reduce the, start of ART can reduce the mortality. HIV-VL is the relapse rate is very frequent in this cohort, in the HIV-VL co-infected patient. So, and prevalence is like, as I told, that is 2.4% newly diagnosed case we identify using active screening. So it's 10 times more higher than background population. So we advocate that voluntary co-slinger testing and HIV testing should be offered routinely for all VL patients. Discussion points. There is need of combination therapy to prevent resistance. There is a scope that combination therapy could be a better option to reduce relapse. For example, high dose liposomal amphotericin B plus miltefosine combination. Also, role of secondary prophylaxis could be useful for some specific cases. There should be an integration between different vertical programs like NACO and HIV program and VBCD. And there is need of clarification of WHO stage 4 definition for HIV. It is written there that atypical dissemination of visual instruments. However, we recommend that it should be changed to all all visceral leishmaniasis patient. So visceral leishmaniasis should be a AIDS defining illness itself. Thank you very much.
Thank you, Dr. Mahajan. First of all, I want to know why you did not differentiate patient as far as the dose of ambisome is concerned between immunocompetent person and HIV infected person, because usually in HIV infected person, the dose of ambisome recommended is 40 milligram per kilo, not 20 milligram per kilo. Second thing, that with MSF resources, why couldn't you provide them? They are only 50 odd patients. You should have provided them prophylaxis, monthly prophylaxis of ambisome.
Yeah.
And so I think you just, it seems that you have just treated everybody and just found that these 2.4% are your positive patients,
yeah,
and given them the same doses. So my question is why they were not treated differently?
After this analysis, from like August 2012, we have started giving combination, a combination of ambisome plus miltefosine. So far we have found a promising result with combination therapy. We have like almost 30 patients treated with combination.
Again, miltefosine is not a very good drug for HIV infected population, because it works through immunity and the immunity is not there. So the best way is to give a higher dose of ambisome and then keep them giving monthly, From Europe there is two studies, there are 3 studies in fact, one on ABLC, one on ambisome, one on pentamidine, which suggests that giving monthly doses of one dose of monthly of these drugs postpones or prevents relapse.
Okay, sir. So in between, we also think of starting prophylaxis, but we plan to develop a formal study, but it never, because of some ethical reason or something, we never planned.
Yes, Professor John.
I'm very curious to know if in some people with chronic infection with the parasite and HIV, co-infected, if you treat for HIV, does the leishmaniasis disease become worse? I'm drawing an analogy from tuberculosis. When you are co-infected with TB and HIV, and if you treat with antiretroviral treatment, the immune reconstitution in the body in a few patients make TB far worse than if that person did not have HIV treatment. So we have to judiciously decide whether you treat TB first and then introduce ART, or do we do it together? Those kind of issues are very, very alive in the TB HIV community. Is there anything like this with visceral leishmaniasis? Anything known about immune reconstitution with HIV treatment? ART makes the disease worse with
To my knowledge, no. We are providing, we are treating for VL first, and then we start ART. Maybe, sir.
Yeah, I think there is always a possibility of immune reconstitution syndrome with VL as well, although it's not well described. But I think these patients are, once they get both the disease, they are so immunosuppressed, because VL also causes immunosuppression of slightly different type than HIV itself. So it is better to treat for a week these patients and then give ART, and then you can avoid the drug interaction and other things. But frank immune reconstitution syndrome has been described from different continents, 1 or 2 cases, but not from India.
I wanted to just clarify, did you say you had CD4 count results of these patients at the time when they were diagnosed with co-infection?
Yeah.
Because did you show us what was the CD4 counts of these patients? I mean, were they all requiring ART as per the recommendation or
No,
well?
in MSF we directly sent for ART, but we have the CD4 count
No,
when they came to us.
Did they have all of them had an indication to start ART?
Yeah,
So less than 350 or?
yeah.
Okay. And
So before, we were providing ART by itself before RMRI don't have the ART. Then we hand over our ART patients to RMRI.
Yeah.
But RMRI has a ART plus center, so they have ART.
Yes.
Yeah.
Yes, sir.
So another question is, as I get from you, the 4 years relapse rate was only 30%.
Yes, sir.
So every patient in this cohort has been followed up for 4 years?
No, sir. Few of them were followed up for less than 2 years. Few of them maybe, as I said, median for one median follow-up time in 2 year study was 1 year. So,
Yeah.
so we censored the data and using
So how
Japan
do-
estimates,
because
it's an estimation of results.
So what I was trying is, what is the comparison of relapse? Because if you look at the Western data before the ART was introduced, everybody used to fail within 1 year or 2 years, almost 100%.
Yes, I think almost everybody relapses.
Yeah. But in
Everybody
here,
relapses.
you are only having 30%. So that's something very
No,
remarkable.
I don't think they are following everybody because a patient with HIV and VL is bound to relapse. Unless we really are able to boost his CD4 to really high levels, these patients are going to relapse. So, but definitely giving ART is a very important and is the key to success in HIV-VL co-infection. So, once you have initiated a treatment for VL, quickly move on to ART and try to bring his CD4 up so that you can at least postpone relapse or maybe prevent relapse. Yes.
Thank you for. First of all, I want you to understand one point. You said that 36 patients were died, among them 6 patients after the admission. My question, all these patients were under anti-leishmaniasis treatment or anti-leishmaniasis plus antiretroviral treatment?
They died before starting ART.
ART, before starting ART?
Yeah.
Okay. And the estimated mortality, as you mentioned, that it increased with years.
Increased
with years, with the duration of treatment, it increased. Just on the 0.5 years, it was 14. On the 2 years, it was 22. In the 4 years, it was 29.
Yeah, it's a cumulative.
It must decrease, I think, with the duration of treatment, because the first time of treatment is the more difficult time for deaths. And after that, the estimated incidence must be decreased, no?
It's a cumulative incidence. So first time, then it's
cumulative incidence.
Yeah.
Okay, thank you.
Sir, I am also from MSF. Sir, I want to add my colleague, as far as a question was raised, what are the scene of the ART? Actually, in the case of Kala-Azar, there is a defined as per the clinical stage of the NACO guideline, as earlier as we discussed, asking from you, sir, there is a atypical disseminated visceral leishmaniasis. So in our project, we are just with the ART consultant, sir, we are giving this regardless the CD4 count, considering it is as a clinical stage 4, we are starting, we are just treating the, we are treating visceral leishmaniasis with the, sir, as we have started added, as he told, that 30 milligram per kg body weight in the total, and the miltefosine as well, which will look into the matter. I will forward it to my expert committee. Thank you, sir, very much. But regarding the ART, initially we were treating the Kala-Azar, and just after the Kala-Azar treatment, regardless the CD4 count, we are starting the ART, sir. So considering it as a clinical stage 4. So as such, there is no provision from the ART center in Sadar Hospital. We are keeping the patient. For 2 weeks under our close observation in the Sadar Hospital in the Kalazar ward. So looking to minimum they described for AIDS, reconstructive inflammatory syndrome, minimum 5 days. So at least we are looking for 2 weeks. Then we are discharging the patient after initiation of ART. Thank you, sir. And thank you, sir, for suggestion. We'll forward your opinion, your kind opinion to our expert to give the ambisome 40 milligram. But nowadays, these days we are treating with the 30 milligram per kg body weight with miltefosine. It was in mind in ourselves also whether does it interfere to the immunity miltefosine. So thank you very much. We are looking for also for such type of answer. I will forward it to our expert college. Sir. Thank you.
There were any more questions? Okay. Thank you, Dr. Mahajan. Now I invite Dr. Paul from RMRC Bhubaneswar, and he is going to discuss the Eltor variant of Vibrio cholerae.
Switch now. This is the switch. Which one? This one. Good morning. My present topic is the re-emergence of Eltor variant Vibrio cholerae O1 causing cholera epidemic during 2010 in the tribal areas of Orissa. In this topic, I will collaborate all my experience of 2 decades in the tribal areas. You see, Odisha is vulnerable to diarrheal disorders, where it put a significant threats, and particularly in the tribal areas, it accounts for large number of morbidity and mortality. So far my knowledge is concerned, when I joined in RMRC, in 1993, we have seen the epidemic in undivided Koraput districts, where the causative agent was Vibrio cholerae O1 Innova normal Eltor strains. From 1993 to 2007, this was due to the normal Eltor strains with the O1 and O139, Ogawa, Innova, started switching over in different time periods, in different place of time. In 2007, there were history changes. The Eltor variant first reappeared in the tribal areas in the Kasipur blocks, where it caused the havoc. Lot of morbidity and mortality was there, with the change of antibiogram. Then 2010, again it reappeared after a gap of 3 years in the same tribal areas. If you see the epidemic of cholera in 2007, the epidemic of cholera due to Eltor variant Vibrio cholerae O1 with the multi-drug resistant Vibrio cholerae strains reported in tribal areas during 2007. The Vibrio cholerae isolates were isolated from the Nala, Chua, stream, river waters. This is the first report from the country and the globe causing the epidemic due to this variant, Eltor variant strains. Then this disease spreads to the coastal areas, where it caused the outbreak in the eastern coast of India in 2009, where the pond water was contaminated. Then also in 2010 and 11, again caused the epidemic in tribal areas. Early reporting enabled the state government to implement control measures. The spreading of the vital epidemic was controlled. This is the study area. In the tribal areas, 2 districts, there is the Raigada districts, 3 blocks, and 1 block from Gajapati districts was most affected. Coming to the methodology, totally 68 rectal swabs are collected from diarrhea patients, admitted to different hospitals and diarrhea affected villages, where it is bacteriologically analyzed. Similarly, 22 water samples are collected from different environmental sources, were tested for the presence of Vibrio cholerae. This is the flow chart for the isolation of enteric pathogens and Vibrio cholerae. Coming to the results part, after analyzing the 68 rectal swab, the Vibrio cholerae were about 71%, whereas the E. coli were 27%. This is the diarrhea, blockwise severe diarrhea affected blocks in Raigada and Gajapati districts. Out of the 11 blocks of Raigada districts, the worst affected blocks were Bisamkatak, Gudari, then Kalyan Simpur and Kasipur blocks, whereas the Mohana block of Gajapati district was worst affected. Then total GPs were about 97, 453 villages, then 2,152 cases, and 43 deaths were reported. If you see the date-wise incidence of diarrhea cases in the 4 affected blocks, it indicates the clustering of cases were reported in 4 blocks in different villages in different time periods, which continued for 3 months. Then we have taking the incidence of first cases and the last cases in each village. We have shown the migration of the bacteria how it can move from one place to another and affecting the four blocks, three blocks. The Mohana block was least affected, so it is not shown here. All water samples were negative of Vibrio cholerae by the time of investigation due to the heavily chlorination of water sources. These Vibrio cholerae were sensitive to gentamicin, norfloxacillin, ciprofloxacin, azithromycin, and ofloxacillin. It was resistant to a series of drugs. All Vibrio cholerae strains were resistant to 100% tetracycline, and they were all alter variants harboring the CTSB gene of the classical strains. If you see the clonality of these alter variant strains from the 2007 to 2009, we have found out that it first originated in Jaipur area, then we have traced back. It has originated in the coastal districts in 1995. While the Calcutta people are claiming that it has originated in India during 1993. This same strain has also gone from Odisha, from Calcutta to the Nepal, through the peacekeeping forces to the Haiti after 100 years, where it caused the epidemic. The seasonal Vibrio cholerae and outbreak cholera in tribal areas, it noticed, it was observed that new areas are reporting cholera outbreak in comparison to the previous years. Tetracycline sensitive Vibrio cholerae strains were reported in 2007, sensitive to 2010, resistant become 2010, then again it becomes sensitive in 2012. The alter variant Vibrio cholerae strains are replicating totally the normal alter strains. We have also developed a quadriplex PCR where you can do the genotype, serotype, biotype, toxar, and tox regulatory proteins in a single PCR assay. If you see the epidemics in 2012, it also affected two districts, that is the Kasipur, Gudari, and Jagannathpur, and Kalansiur blocks of Raigad district was affected. Similarly, at the same time, the three blocks from Kalampur, Jaipatna, and Juragarh blocks of the Kalan district was affected. This is the sociological behavioral strategy. We did some things. The total tribal people dominated by ST by the SC population. And then cultivation has 80% population. Illiteracy has more than 80%. Source of drinking water in the Mohana area were the tube well and dog well. From Kasipur is the tube well and chua water. And then Daswantpur area, it is mainly the river and the stream water. People depend on the tube well and chua water for the cooking purposes. So where the risk behavior is concerned, disposal of the waste is 100% outside. Defecation 100% outside. Eating dry meat and beef, Kasipur area 70%, Lakhimpur 82%. Cleaning utensils in Mohana and Chua area, Daswantpur, Kasipur, Lakhimpur area the river water. Diarrhea clothes washing river and stream water, Chua water. Diarrhea treatment facilities after 2007 they are doing depending on the hospitals, then the local dysentery patients. Source of the spread of the infection they don't have any knowledge. And they have the knowledge that the heavy rainfall is due to the spread of the disease. The prevention diarrhea, they have the less knowledge. Water is the major sources for the source of infection, the stream water during the workplace. Coming to the discussion part, contamination of water sources is the major cause of transmission of cholera. During the rainy season, people usually go to the paddy fields, drink water from different water sources like Nala, Chua, river and stream water, get infection, which is already published from our 2007 cholera epidemic. This outbreak mostly confined to a schedule caste and schedule tribe population who are socially backward, mostly illiterate and poor. Majority of diarrhea cases were over 25 years age group. The spreading might be due to the household contacts, unhygienic health practices, contamination of water sources, and population migration, etc. The infection spread to different villages of Kasipur, Kalansiur, and Bishopkandak blocks of Raigad district and Mohana block of Gajapati district, which are close to each other. The early reporting of the pathogen, isolated from the stool samples, chlorination of different water sources, and institution of appropriate control measures kept the cholera epidemic safe in this region. A high percent tetracycline resistance with other drugs was seen for the first time, with a contrast to the 2000 cholera epidemic. Emergence of ultra variant tetracycline resistance strains of Vibrio cholerae was also cited from the Assam in 2012. Similar tetracycline resistance strains has been reported from Bangladesh in 1979. Tetracycline resistance strains of Vibrio cholerae have been reported from 2010 from the tribal areas, which is the first report from this state. Tetracycline is the drug of choice for effective cholera treatment. The tetracycline resistance strains were also reported from the epidemic of cholera in Tanzania. In similar situations, from Madagascar, other regions are reported. So the tetracycline resistance of Vibrio cholerae strains are reported in Mozambique and also from the Calcutta. Notably, tetracycline resistance strains of Vibrio cholerae Uwanogawa have been responsible for major epidemic in Latin America, Tanzania, Bangladesh, and Zaire. This is the precipitating factor, what I have seen in a couple of 2 decades. Sudden stoppage of the rain during June to July, with high temperature causing the evaporation leading to high concentration of nutrients in accumulated river in water, favoring high multiplication of the Vibrio cholerae. Cholera outbreak starts due to intake of contaminated water and spread rapidly due to unhygienic practices, population migration, etc., as with other factors. This is a scene where the remote areas, poor communication facilities, how the patients are transported in different villages. Coming to the conclusion part, the present study indicated that the re-emergence of ultra-variant Vibrio cholerae strains in the same tribal areas with altered antibiogram after a gap of 3 years, and it spreads in the tribal areas which needs close monitoring. Thank you.
So, Dr. Pal, this is really a serious matter, and what do you think is the cause of this? I mean, is there any hand of using drugs in subtherapeutic doses or etc.? Because how the resistance will occur? Because your explanation that your explanation for infection is all right, but how the resistance will occur unless the bacteria is exposed to these drugs? So that's my concern.
Actually, in 2007, when the tetracycline was very sensitive, massive use of the drugs were there. In 2010, what we have seen in other areas where the people are not exposed, they are become sensitive.
Okay.
So this may be due to the difference of the area and patient's exposure to the drugs.
So there is a need to control the use of drugs in these areas.
Rational use of the drugs.
Yeah,
is
because
necessary.
they are being used indiscriminately, it seems. And as you have said that they become sensitive to tetracycline in 2012. Anyway, now the question from audience. Professor John.
In my first talk, I included cholera as a neglected disease. This paper illustrates that particular point. India makes the globally used cholera vaccine. It's a bivalent, oral, kill Vibrio cholerae vaccine. It works against both O1 and O139. It's being used in Haiti. But in India, cholera is not on a controlled trajectory. These communities deserve cholera vaccination. And I think, I hope you will recommend to the ICMR, DHR, and establish a cholera vaccination demonstration project here, so that you can then show how vaccine works in a place where predictably you have cholera outbreaks and large-scale outbreaks. I have a second comment is that, two other comments. One is, everyone may not know that Vibrio cholerae is a saprophytic organism in water bodies, and the copypods contain Vibrio cholerae in a non-cultivable form, and if you put into rabbit ileal loop or humans consume it, it becomes the Vibrio cholerae that can transmit from human to human. So that's how Vibrio cholerae is present all over India in almost all communities. But in the ancient medical system of India, microbes have not been recognized. So even today, the Ayurveda physician would say it is a theory that Western medicine teaches us as a microbial causation of disease. So deep down in the cultural belief pattern of our people, water is a cleansing agent. How can water be contaminated? So we have long ways to go in addressing these kind of issues and teaching people about the invisible microbes that still exist, and we need to teach microscopes in schools. I don't know how, but we need to address both these issues. We have vaccine available, we have the problem area, use the vaccine, demonstrate that vaccine works. Secondly, wherever we can encourage the introduction of microbiology into minds of children in primary schools, where somehow break that barrier of disbelief in microbes. Thank you.
Actually, after the 2007 epidemic, we have 2 field stations in the tribal areas. We are doing the surveillance throughout the year. We can detect the source of the infections and the spread of the infections, as a result of which the possible outbreak is checked. My major concern is why the tribal people are most affected, where the bacteria goes. We have seen that it is only seasonal. Whereas in the coastal district in the Puri area, we have seen that it is totally endemic throughout the year. Where we are doing the vaccine trial, the phase 4 vaccine trial is going on there, it is showing the efficacy of 60 to 70%. We have also planning or advice to the government to implement in the same in the tribal areas. That is my major concern to look for the future perspectives.
Any more comments, questions? Yes, there at the back.
Hello to all. I am Gupteshwar Patel, a student of Master Public Health at Bhubaneswar Institute of Public Health. Actually, I was conducting a study of treatment delay for the MDR tuberculosis. At that time, I got to know that the MDR TB is for the ofloxacin, which is commonly used by the informal health worker at the tribal setting. So, as Sir has given one of the slides that a class of antibiotic is there which is resistant towards the cholera. So is it for that informal health worker is happening? Is it for that or what? I don't know actually. So can you please explain that, is there any contribution of that informal health worker at the tribal setting for that resistance or what, sir?
Sorry, I could not follow you. Again, repeat.
Yes. Actually, I was talking about the ofloxacin is an antibiotic.
It is giving sensitive.
Yes,
giving
yes,
good results.
it's a second line treatment for the treatment of tuberculosis. And informal health worker at the tribal setting, they are frequently using for the symptomatic treatment of the disease. So is it, as you've seen that a class of antibiotic is there which is resistance towards the cholera. So is there any contribution of that informal health worker towards that antibiotic resistance or what?
We are doing the monitoring in the tribal areas. 2 units we have set up there. Throughout the year, we are doing this work, and we are giving the information to the concerned health authorities.
Okay. Okay. Thank you.
So it is taken care of.
Professor.
Thank you very much for a nice presentation.
Thank you.
You just mentioned that you have a field station set up in these 2 districts, and you're monitoring actively what is happening. Is there any collaboration between your field stations and the existing district health services? Because they also have an integrated disease surveillance program. So it would be interesting to see whether they are picking up these diarrhea cases, because you are interested in picking up these diarrhea cases, whereas they don't want to pick it up because of various reasons. So is there a match between these 2, your reports and their reports? Are you looking at all these factors?
We have close collaboration with the IDSP, Government of Odisha, and District Headquarter Hospital, CDM office, and the concerned PSC. There is a networking.
Okay.
So everything is going on through proper planning, and reporting is going on every 48 hours.
Okay. Thank you.
Sir, I have a question. I want to know more on the cholera vaccine, oral cholera vaccine. What is the status? You mentioned once that what is the status going on in the coastal region? Any, trial is going on how long it will be effective? If you give one oral
vaccine is giving efficacy of 60 to 70%.
But it is a lifetime, or for certain duration it will act on that?
It will act to maximum 2 to 3 years.
Okay. And initially it is done in India, or now ICMR is going to do anything with that?
About?
Cholera vaccination?
This is the present cholera vaccine scenario. Santa Cruz is giving the whole cholera, 139 killed vaccine.
Okay, and then for, it will be bivalent? What is the strains it will be covered?
Sorry?
What is the strain it will be covered by this vaccine?
This vaccine was tried in Calcutta, now this is going on in Odisha.
No, I am asking the strain.
Strain?
Strain, yes.
This can also control the normal altered strains, also it can give the prevention. 0139 and also the altered variant strains. It can give the protection.
Okay, thank you, sir.
You want to say something? Okay, thank you very much, Dr. Paul. And it has been a very nice and vibrant session, and with very high quality presentation, and I congratulate all the speakers. And let's give them a big hand.
Thank you.
And I close the session. Thank you very much.
With the permission of the chair, sir, on behalf of the organizers, I would really like to thank the session chair, Professor Shyam Sundar, for moderating the session so well. And we request you to accept a small token of appreciation from our side. I would also like to thank Professor Hamid Sahibi, on behalf of all the organizers, for effectively co-chairing this session. Kindly accept this small token of appreciation from our side, sir. I would like to thank all the 8 presenters for the interesting presentations, as well as the august audience for your kind attention and for making this session very interactive with your feedback, suggestions, and questions. I would like to make one announcement before we break for lunch. The next session is a dynamic poster session, and the guidelines of the same will be briefed after the lunch. So I request all the delegates to kindly have lunch and please assemble in this hall again, wherein the guidelines for the poster presentation will be briefed. And one gentle reminder, a kind request to all the delegates to kindly confirm their departure timings at the travel desk before we assemble here for the poster session. The lunch is organized just outside this hall. I request all the delegates to kindly proceed for lunch. Thank you.